Should.
There you are.
All right. All right, we're gonna wait just a few seconds to let everybody join in the webinar. But thank you to everyone who is here already. We are excited to talk about the new AIM aligner tonight with Dr. Thornton and Dr. Carsonson. Just a quick introduction. My name is Kelly McDuff. I am the marketing and sales manager over at Airway Management. And we are really excited to talk about the AIM aligner tonight. Thank you, Dr. Thornton and Dr. Carsonson, for taking time to go through this semi-new product that we launched this year. And I'm just going to let them take it away. So off to you guys.
Keith, you want to
All right.
say anything?
Just glad to be here. I guess I'm more passionate about this product than almost anything else that I've invented, because I think this is one of the things most important, to have people have a tool so that they can manage whatever occlusion they come in with and be confident that they're not going to screw somebody's bite up. So this is something that, from a restorative point of view, my background as being a restorative dentist, was taught at Pankey for years and in the restorative academy and things like that. So really my background is occlusion and dentistry, and we've seen some real morbidity with this. And so I've been really focused on this my whole career since we started in '92. So really that's my background, why I'm so interested in this field. So this particular area.
Yeah, I can second that, because I met Keith at Pankey Institute all those years ago. It turned out we practiced just one town apart, Fort Worth and Dallas. And so I would go over to Keith's office, lucky me, to get mentored. And Keith's passion's been there from the start. And honestly, guys, when I've been watching this for a lot of years now, 25, 28 years, and seeing Keith as interested and as engaged as he is with this product is really heartwarming. So that's the level of commitment that Keith Thornton has and Airway Technologies has for making sure that you can stay a good dentist, be a good doctor also, and have a pretty easy time of it in the clinic. So let's show you what we want to show you today about the new AIM aligner. Look good, Kelly?
Yep, all good.
Okay. So yeah, there we are. And traditionally, what dentists have done is worry about how the teeth come together. And we've done a lot of work to try and make sure that that stays stable. It's comfortable for the patient. It meets the restorative requirements. It looks like it's supposed to, and from our training and our advanced thinking and all the parts that we put together to make sure that our patients are comfortable and functional. Okay, that's good. That's what we need to do. We're the only part of medicine that does that. But now we throw into the mix something that can disrupt that, and that's a mandibular advancement device. And we're not going to spend time today justifying the mandibular advancement devices as a therapy for sleep disordered breathing. That's given. You guys wouldn't be here if you didn't know that part. But you're probably here because you're either curious about what is this new AIM aligner, or you're facing clinical questions in your own practice about, well, what do I do with my patients? How can I make sure that doesn't happen? And I don't want to deal with patients with bad bites just because I did this forward device. Or I'm thinking about getting into this, but I'm so worried about becoming a, quote, bad dentist that, it's kind of holding me back. We want to allay some of those fears tonight. And Keith and I are going to kind of go back and forth with this. Honestly, guys, we don't have a script, and questions are very much encouraged. Please put them in the Q&A. And if you want to put the questions in the Q&A, everybody sees them. If you have a private question, put it in the chat, and wait a minute, it goes the other way. If you want everybody to see your questions, put them in the chat. If you have a private question, put it in Q&A, because then Kelly, all the leaders, Kelly and Keith and I will see those. But we'll get to all the questions. So don't feel bad about any questions here. And Keith and I will have our conversation back and forth about the AIM aligner. Kelly. All right, I'll talk for Kelly. If you're here online, all of you guys, if you want a free tap mug, and who doesn't want that for cocoa and toddies coming into the winter season? But put your address in the chat, and we'll get all those, and we'll mail you out a tap mug. So we're going to talk today about some of the science and the purpose. Why did Dr. Thornton invent the AM aligner, and what's different about this versus its predecessor? We'll talk a little bit about other choices you might have, some new things that are about the AM aligner that I hope you will see will solve some of your clinical issues. And then Keith and I have a lot of experience in fitting the new AM aligners and a lot of experience fitting the old ones. And so we're very happy to share techniques and answer your questions, those kind of things as we go forward. Keith.
Okay, so we'll go to the background of why we started this, the science, and I'll go through that, and obviously the purpose of the aligner. Next slide.
Okay, sorry.
So I first started to develop the regular first tap appliance in '94. Actually, I started in '92 and fooled around with it and changed that. So then if you go back one,
oh, well, okay.
You went forward. So you're going forward. There you go.
Sorry.
One more forward.
All right.
All right. 95. I wrote a little paper. It's the first one I wrote, and actually it's the only one I published because I feel very strongly that there's too much people that have conflicts of interest writing papers and doing the research. So I got out of the business, but this is the first thing that I looked at over 200 of my first patients. And what I found that we had some significant orthodontic and orthopedic movement of teeth after 6 months. So I said, okay, what can we do about that? And from my background of restorative dentistry, we had leaf gauges and ways to get people back in centric relation. And so I developed a little cut up some squares out of football mouth guard material and started having people put them between their teeth and chew on them and try to get the teeth back together right. And always what I try to do is get the initial contacts in whatever centric relation they have, maximum intercuspation, and that you can bite down and have shim stock and it will connect on shim stock. So really what your whole goal in this whole thing is that that patient should come back in with the same contacts they did 6 months, a year ago, 2 years ago. So that was my real goal. And so next slide, let's go.
Yeah, in our practice, we take a shim stock inventory of every tooth pair that holds the shim stock around the arch as part of our initial examination, just so we have that baseline data.
Okay.
Come on, I'm trying. There it goes.
So there was one study that Alan Lowe and Fernando Almeida did on both negative and positive effects after 7.5 years of wear. They got 70 patients back and looked at what happened, and 14% had no change. Interestingly, they determined 41% had favorable change and 44% negative change. So the favorable change mainly was orthopedic, in that people with class 2, division 1, division 2 became less retrognathic, and so they considered that positive change. The negative change, which I put down there, is really, I think, from appliance design, material and mechanism. So what are the negative changes? Orthodontic movement of teeth, obviously, open contacts. One of the things I found very early, we used to use hard acrylic and reline them like we did down at the Pankey Institute. But once you put pressure on them, if they get loose at all and come up at all, you're going to start moving contacts, particularly between the first and second molar. So one of the things I did, and why we have the design, is to go over all the teeth and grab a hold of them over the undercuts so that we don't see moving of teeth. So we eliminated that very early on. We see inclination of anterior teeth because of that, open bites and reduction of crowning. This is from Almeida, but if you look at the study they did it on, it was the Clearway, which really had kind of a funky protrusive device in it that affected that. So, but I think it's a good idea about what orthopedic changes you have in it. Next slide.
Yeah, and one of the things to really take care of that inclination of anterior teeth is to make sure that you wrap the distals of the last lower tooth. That's such a critical step that's not always taught, except in, I always teach it, and other people always teach it, but it's not always what you hear first. If you wrap the distal of the last lower tooth on, then it's very difficult for the lower teeth to move forward. It's harder for open contacts between those last two molars. And so as you do your scans, as you do your impressions, as you instruct your manufacturers, make sure you tell them that they must wrap that distal, that last lower tooth. The upper is not as critical because the anchorage on the upper is into the alveolus, but the anchorage on the lower is pulling the teeth forward. And so that's a big thing that we started years ago. And I really don't give my patients a lot of concern about movement of actual teeth.
I would agree with that. And that's why if you want to shorten the upper and not contact all the teeth on the upper, you can cut off the second molar on the upper very easily and not worry about it because you're shoving back on an arch. And so you never see open contacts usually on the upper. Now, one of the people, we used to use ball clasp and we saw open contacts with that. So most people have gone away from that. So we just don't see that happen.
Right.
So this is the what I've called long-term orthopedic effects of the mandibular advancement device. So that's the thing that really we need to look at and be aware of and want to know, do we want to actually inform the patient that this can be a positive or negative effect? Steve, you talk about the difference in why how you deal with patients on that.
Sure. Oftentimes when we see our patients that have an airway problem, it's because the skeletal base does not support the airway in the way that really is great for breathing. So the maxilla is back too far, the mandible's back too far, everything's too narrow, all those things. If we're sitting there with a middle-aged person or especially a younger person and we see that, then it's part of our differential to understand the skeletal base. It's part of our good being a good doctor to say, look, there's other choices out there. You can go to the orthodontist who understands and coordinate with a surgeon, and there may be ways to correct that skeletal base here in your, while you're 35, and so you can enjoy a good open airway using a tap appliance for a few years as you plan this, and then go and correct it. And so then you can face your next, few decades with a problem that's already fixed. Well, if we have a patient that's using a mandibular advancement device and we recognize that their skeletal base is part of the problem, and then they come back and they show us, wow, look at this, my jaw has moved forward, my jaw condyle process has adapted, so now my teeth don't come together just the same. Well, I can remind them that, gosh, one of the ways that we talked about correcting this in the first time was to see the orthodontist and orthopedic surgeon, oral maxillofacial surgeon in this case, and get everything fixed. And so all that's happened, patient, is that this adaptive process that's caused your jaw to come to posture forward and your teeth not to fit the same, all it's done is really just directed you into that other choice that we discussed before. So it's not really a huge negative if it ends up with a nice positive outcome that they can function on comfortably and breathe well for a few more decades after that. Obviously, it's better to choose straight up, but sometimes these adaptive processes are not always seen as a big negative.
Well, the other thing is most people don't perceive it as negative, rarely, nor do they complain about it. So, as I say, most of the time I discover it, and the patient says, "Well, doctor, I don't really care, but don't take away my appliance." The other thing is, my wife had a problem with her airway and orthodontics, and my good friend orthodontist recommended jaw surgery. And I said, well, that's not going to happen. So she also had at the same time been treating her for about 20 years for a TMD. So we put in an appliance, and we were able to grow her jaw 5.5 millimeters so that she never had to have surgery. She did have orthodontics. So it was a pretty cool way to, if you understand that, and the patient understands, a great great opportunity to do something positive for these patients. So let's go to
I got something else to say there, Keith, because
okay.
when you were taught, when I was taught, when many of our listeners were taught in dental school about the stability of the condylar complex, it kind of takes its shape in the later growing years and it matures a little bit over the next 10 years, and then just stays the same for a long time unless we do something to disrupt it, like an accident or a soft tissue injury. But how do we know that? We know that because all of those years prior to oral appliance therapy for airway treatment, so years prior to the middle 80s, all those years, we had no stress forward on the mandible. So nobody studied it. And so now we've had a few decades of putting intentional posturing forward of the mandible. I think we're discovering new responses of this complex. I think it's because we never asked before, because we never had to. And so what we're seeing now is not necessarily some new or some thing that violates what we were taught. It's just that what we were taught had no idea. So it's new information. So I'm not worried about this. I'm kind of excited to see what happens when we apply adaptive pressure to this portion of our bodies, because our bodies are clearly adaptive anyway.
Well, and as we know, the jaw joint and the disc and that complex is different than any other joint in our body. We have a fibrocartilage as a cartilage that has mesenchymal cells, and with that can differentiate back into chondroplasts. So if we'll go back and look at, you keep going forward. So can you go back there, Steve?
Go back?
Yeah.
Yeah, that one.
Okay. So this was a study in, let's see, go one forward. Yeah. Okay. So
this is what you want.
Yeah. As I said, negative and positive, we get condylar growth, remodeling, fossil remodeling, elongation of the body of the mammal, and it's rarely just muscle. So very early on, I was trying to get these people back, and all of a sudden I said, oh my gosh, they don't go back. I can't get them back into normal maximum occlusion. So that's where we started looking at it. And this is one of the things that Lowe and Amita said.
Yeah, but look at the date. That's 2006. And so the patients were treated in the early aughts for that.
Right.
There's a lot of studies that I did a quick survey again, but I've looked at this before. There's a ton of studies out there that have done careful examinations with cone beams now that they didn't use back in 2000 in early aughts there. And that's a study model analysis. Now we have cone beams so we can look at condylar position now. And this has become a non-factor. This becomes something we can tell our patients that, yeah, you're unlikely to have trouble with your jaw joints. You're unlikely to have significant morbidities with this. There's things that we can notice, but that may not cause you any problems at all. And that's really what you can hang your scientific hat on there.
Right. So these are the guidelines of the ADSM. You can read them: exercise, occlusal guide, or the primary first line of treatments to manage occlusion. So that's been published, and that's the way the ADSM guidelines are.
Yeah, and it's really physical therapy is all it is. I mean, if you have any kind of injury to a jaw joint or to a joint in your body and you go to the physical therapist, they have you do exercises. They have you do range of motion movements. They have you stretches. They have you do things. We're applying the same principles to the jaw joints.
So this was a case report a long time ago. This was my wife's uncle. He snored. She remembered growing up that they slept in separate bedrooms. He would wake her up at night. So he wanted to get an appliance at 83 because his first wife died and he had a girlfriend. So he wanted an appliance. He did have on a pulse oximeter significant apnea. We successfully treated him for 7 years with a tap. He was permanently protruded, as you can see, and after 5 years, had no dysfunction, normal function. At 90, he lost his girlfriend, so he stopped wearing it, and he died at 95. The nice thing is that both he and his wife gave their bodies to the medical school, and the head of head and neck anatomy was a good friend of mine. And so we got Uncle Sid's head and was able to look at his jaw joints. So this is his postmortem CTs. And as those arrows show, absolute normal condylar fossa relationships. Next slide there. And this is a reconstruction of it, and absolutely normal. And my friend who's head of head and neck anatomy at the school happens to be an oral surgeon. So what he did is cut and almost do like a mandibular resection and move the lower anterior portion of the mandible back, and the teeth fit perfectly. Next slide there. So, and the reasons for the protrusive change, as we say, is this dental compensation? I don't think so. This is certainly not muscular adaptation. So I think this was skeletal adaptation and growth in the changes in the condyle and actually growth of the condyle.
So, Keith, you think Peggy's uncle is pretty much an outlier, though. You don't see that kind of movement on many of your patients. I certainly don't.
I don't at this point, but because I treat so many severe patients, and if you look back at Hookema's study, and they're out at 80 to 90% of their maximum protrusion. So I saw a lot of these because of the patient population. I hardly had people that were just 50%. So we were treating these severe patients, and I saw them in these severe patients. That's where I saw it all. And also, the patients had the ability, because of the way the design of the appliance is that if they started snoring, they had problems, they would protrude themselves. And I didn't have them back often enough. And after 2-3 years, they come back in and say, oh my gosh, here's what we got. So these are kind of the experiences I've had. So this is why we've done what we've done. Yeah. I don't see it now.
Right. Well, part of the is adding the mouth shield and the nose. I call it the nasal breathing trainer to the TAP family of devices, but that's not what we're talking about tonight.
Yeah.
So here we go.
Okay. So this is again from McNamara, a very famous orthodontist from Michigan, done a lot of studies on monkeys, and really saying we can remodel the condyles by adding vertical or stimulating this by putting devices in these monkeys' mouths. So we know that this condyle can remodel. So initially it's adaptation and muscular function. So initially, first 2 or 3 days, whatever, it's like your muscles are holding the jaw forward. But after a very short period of time, it can be permanently forward and it doesn't go back. So you get a morphological changes in these patients fairly quickly if you don't really get them onto something like the AM liner. So this is just kind of a cartoon of how the jaw joint and the disc works. And we know we have a thin part of the disc, a little pocket, almost like what I call the pocket of a catcher's mitt. And as that condyle moves forward and the thin part moves forward, and it's and then the disc follows it, and the blood in the disc behind the retrodiscal tissues move forward. And then as you move back, that thin part of the disc moves back. So that's a typical normal condylar disc function.
Now, one of the things to keep in mind is that every single joint in every patient is an adapted process, because it's adapted to the function that the patient's put itself in, the orthodontics that the patient might have had, what they've chosen to chew, how they grew up. All kinds of things affect this system here. So there's an adapted jaw joint in the left and right of every single human that you see. So as you bring your patients in, it's a great idea to get a thorough history of what has gone on for their jaw joints and do a good assessment. You don't need MRIs and X-rays, and you don't need to be a TMJ expert, but you do need to be able to assess for what you're dealing with. That way you can set expectations appropriately for this.
So with condylar remodeling, in the first slide, the patient is not able to get back. So the retrodiscal tissue fills into that space, and then we have condylar remodeling, chondroblast, and what happens that our jaw and the condyle grows back and up, and actually the fossa remodels. So now all of a sudden we've got a longer condyle, the fossa is remodeled some, and I think we may get a lengthening of the mandible itself. That's what I visualize as what's happening with the condyle.
If you study CBCTs, if you have one of those, and so you get a really good view of the condyle and ramus complex, you can watch, you can see some pathologies. You can see flattening of this and straightening of that. So under pressure, these bones are definitely remodelable, right? And so it's unreasonable to think that if we add some pressures going forward, and therefore retrusive pressures from the attachments of those tissues to that bone, it's kind of unreasonable to think nothing's going to happen. Why would it not happen? So as we contemplate remodeling of this complex, it makes logical sense. So now, what are we going to do about that?
So our goal, obviously, is to reestablish their presenting occlusal and maxillomandibular relationship in the vast majority of patients. We don't necessarily want them to come forward unless we really plan on that. So what I found out is what we want, this incredibly simple, very quick, and relatively inexpensive to have these people get back to what their normal occlusion is, and that it's easy to use. So this is why we came up with this device initially, and we had a different one we'll show you, and now we've got this one. Several different things, very quick to use, easy to understand how to heat it, and then we put a handle on it so that the patient can grab hold of it and put it in correctly.
As you'll see it function a little bit, it captures slopes of the teeth. And those slopes are what guide the jaw back to where it came from, because those same slopes program the coordination of the closing muscles to put all the parts back in the right place. So we'll use those same slopes, that same proprioception, that same muscle memory to reestablish occlusion.
So what we're going to talk about is a lot of people have wondered, oh, I liked the original the AM aligner, the pink one, why'd you turn it, whatever. So what we're going to talk about is why we changed, why I like this better, and went to the new. And once we got the material that we have with the new AM aligner, and what's the difference. So as you can see, we got the two different ones up here, and we'll go through that. So what do? We have a simple black plane. It's thinner, more comfortable, resilient, flexible. We have irradiated thermocryl. So this is pure thermocryl, polycaprolactone, that we have irradiated. It's a polymer that's irradiated so that it maintains its shape, and it's a little bit stiffer, doesn't flow quite as much as pure thermocryl, which just turns like putty. We have a tab for people to grab a hold of, and this is really ideal for the patient, so it helps them place it in the right place. We have a little tab so that they can put it in the midline, and it guides the anterior teeth, and it provides this point for them to start with.
Yeah, and one of the things that's not really flexible, Keith, I think I would argue that word right there, because it is a rigid guide. It's not like that tab that you started with a mouth guard material. It's not another one of those. This is a rigid guide, so it can use the rigid surfaces of the teeth against this material. Now, it is a slippery rigid guide, and so it has nice smoothness to it and low friction as they bite.
You're right, and we shouldn't have put that in. It's very resilient. In other words, it can bend, but it goes back to the same force. It is not, it doesn't warp. It stays that. So you're exactly right.
Yeah. As many times as we looked at these slides, and we didn't pick up on that before. Oh, well.
Yep. So here's the original design. The material had Kevlar in it to make it tougher. It takes a perfect impression teeth. You can make one of these and put it in 6 months later, and it fits the same. The problem is that with the Kevlar in there, you couldn't bite through it. It didn't flow well enough. It was too firm. Patients couldn't bite through it, and it doesn't get the condyle in the original position. You put anything between the teeth, I don't care what it is, unless it's mylar, you can't get that condyle disc relationship back to where they have the original contacts in citric occlusion or maximum intercuspation. So after a while, we figured this out and said, well, that's not really working well. So
yeah, so think about it in restorative dentistry. You go away from the big, thick articulating papers that you want to use, that you start with maybe to adjust occlusion of anything. And why do you go to the super thin ones? It's so the condyle can function in its good position, and you can mimic normal function of that occlusion using super thin articulating paper when you're checking your occlusion. So why wouldn't you want to position the jaw back in that kind of a relationship if with your morning repositioner? Same kind of principle.
So we found out that having posterior parts of this the AM aligner was too thick, so we cut it in 3 pieces and just used an anterior jig. And as you can see there, we have a bite down, and you can almost see light through. You can see light through the contacts in the anterior teeth, although the anterior teeth don't touch. You don't have contact with the anterior teeth, but you have a location of that anterior thing.
Well, sometimes you do. They put a hole in it, and that worries patients because they see a hole in it and they think, "Oh my gosh, it's going to break." And sometimes this thermocryl does break a little bit. And Keith, you may not remember this. This has happened a long time ago, but you and I were teaching a class down at Pankey about airway issues, and you assigned me the task to teach the class about AM aligners. And so everybody was demonstrated a full arch AM aligner like we saw in the previous slides. And everybody was just about to break up into their pairs to go make these on each other. And you walked in and said, "Oh, guys, let me show you how we're doing it now," and proceeded to cut it in thirds and talk about that. And so I asked, I said, "How long have you been doing that?" And you said, "Oh, about a week." And so that's innovation.
Yeah. Yeah.
Anyway, so my trouble with this design, and I've been doing it this way ever since that day in that clinic. And I use these ammo liners like this. I also use the beads to do the same thing. And the problem that many patients have is they can't seem to figure out how to put it on their teeth. And if their lower teeth are really crooked, it can be challenging to get it lined up just right. And so they end up breaking it, or they end up losing it, or it doesn't really look like a professional piece of equipment. I think the full arch one does. I think it looks like something that's intended to be for them. I think this little one, which works better, doesn't look as good as it should. Now, I've used it because it's so effective, but it doesn't work as well for patients who don't have a lot of overjet and overbite, because there's not a lot of space to put the thermocryl. It doesn't work as good for an end-on-end bite, because there's no slope to leverage against the condylar position. And so there's some limitations in making it cuspid to cuspid like this, but in my hands, it was better than the full arch one for a lot of patients. But I always had both of those tools available.
Good. So here's a patient example that I had wearing one. She couldn't fit it back on her lower teeth right. And as you can see, after 1 year, this is what where it was. So she wasn't getting this back on her teeth correctly and using it enough. So we said, okay, I've got to have something better than this. So that we went on.
Yeah. And I've had patients that have rinsed this under warm water and they're holding it in their fingers and they bend it. Then it never fits correctly again. So then they abandon this therapy and they don't have the easy way to make it happen. So what's new?
So as I say, the radiated thermocryl has a little stiffness to it. If you heat it up to the correct temperature, it's easier to put in the mouth. You got this handle, patient can use it, put it in right. It covers all the teeth. And the main thing is like Steve was saying, is once you bite through it, the thickness of where you see the light through is about the thickness of the mylar strips we have. So we know we're getting right back into the same occlusal relationship we started with. And a lot of times, if you want to, you can use a second one as something that you can keep in their records or whatever to show that this was the original occlusion. So it's a kind of fun thing. A lot of times we'll make 2 of these for patients.
Yeah. And the slopes, again, the slopes of all of the teeth are engaged to direct the forces. And when they get, what we tell them is to bite gently on it at first, gently on it, increase your pressure. And then when you got it close, when you feel like those teeth are coming together, you feel your muscles correctly, then bite as hard as you want, because you're not going to hurt this. And that's really a comfortable thing to do for that. And nobody's broken one yet. Nobody's warped one. Well, yes, they have warped one yet. I'll show you a video of somebody who warped one. But so Keith, why did you put people don't like change? Because my patients don't know any different.
Well, we've had some people that have complained about, oh, I like the old one better. And so part of this is saying, okay, here's why I decided to change this. And I think it's a very positive change. And we're going to show how easy this is and easier it is, and particularly for people to be able to use it effectively and come out with the what you want to have with this. So it's a little bit of, it's like me teaching saying, well, I don't do it this way, I do it this way now. I'm just going, I just change it when it gets better and kind of don't tell anybody. So
Right.
anyway, that's why you're on this thing, you know.
All right, so there are some other choices out there. There's a lot of other choices out there about how you can help guide your patients back to good occlusion, because Dr. Thornton doesn't have the monopoly on being concerned about occlusion. Of course, every dentist wants their patients to have a good bite, and many different manufacturers have come up with different schemes for this. And some of them send out little tabs made out of what could be bite guard material, just like was started, decades ago. But you can choose milled devices, and I've tried a couple of these different kinds across this page here, and these aren't ones that I made, but you can see a milled device. And when I made those, it's milled out of hard acrylic, and so when you put it in your mouth, it's that, and your teeth fit very tightly into it, so it's not really very comfortable to go from a forward position into MIP. Now, once you get that occlusion right, it feels perfect because it's milled to be perfect. But getting from where they take their mandibular advancement device out and put this in the first off, it's not as comfortable to go through the process. The 3D printed one, that's fine. That looks like the original AM aligner, but there's no contact to it. So you don't know whether it's working or not. You don't know whether it's fitting or not. And so you put this in, you exercise on it, has a lot of good properties to it, but the patients don't really feel like it has as good of programming for when it's finally done. How do I know when it's finished? You take it out and try it. Well, with the new AM aligner, you know it's done when you're all the way into it. And in the formed ones, these are the ones I just don't really understand, because if you look at where the contacts are there's nothing that tries to put the condyle back in the right place. The angle of forces is not there, and the patients can bite anywhere along that occlusion. They're not guiding their jaws back to where they came from. So I think this might be comfortable, but it doesn't make any sense to me from a physiology and anatomy standpoint. And so I've never used one of those like that, so I don't know. And so you work on that a little bit, and you take it off and see if your bite works, and put it back in and work on it a little bit and see if your bite works. Maybe there's masters out there that can do this one, but it's not going to be as simple as what we're talking about tonight.
So we'll go through the techniques.
Yeah. So look carefully at that picture, though. And that's what Keith has been talking about. See how clear it is back there. When the patients are biting all the way through it, that's what you want to see, because you want that MIP, you want that representation of tooth contact in the posterior. And it's really important for you to know which ones you expect to contact. So if you've done your shim stock baseline, so you know that, these 3 molars in that bicuspid contact and this other bicuspid over there doesn't. Well, as you see the imprint into the AM aligner material, into the thermocryl, you can also see that it matches up with what you expect from your initial baseline inventory of tooth contact. And when it matches like that, you can have confidence your patient actually gave you the right bite when they were closing together. So here's a little
Before fitting the aligner, place the aligner in your mouth and feel your front teeth hit the bump, also known as the anterior teeth guide. This will help you get a feel for where your teeth are supposed to be when you fit the aligner. Using hot water, place the aligner in the water until the bump is right at the water line. Wait until the aligner bite plane becomes mostly clear, about 15 seconds. Be careful not to overheat the aligner, as it will lose its structure. Remove the aligner and gently shake off the excess water. Using a mirror, lean your head back and place the softened aligner over your lower teeth. Make sure your front teeth hit the anterior teeth guide. Bite down firmly on the aligner into your usual bite position. Put your fingers on your jaw clenching muscles and squeeze as hard as you can for at least 15 seconds. Your fingers should move outwards as you clench, and you may feel a little strain into the jaw. Try to bite all the way through the AM aligner. Relax and continue biting for 3 minutes until it cools. If it's still sticky, it's not fully cooled. Carefully remove the AM aligner from your mouth using the tab. Hold the AM aligner to the light. You should be able to see light where your teeth come really close together. This is important to show good contact of your teeth.
So we'll go through this. You train your patients to touch on their back teeth, tap, tap, feel their master muscles. And I always make sure that when they tap on their back teeth, they're not hitting there's no emphasis on their front teeth. So that gives us an indication that they're back in their maximum intercuspation.
So we're building this, of course, at their delivery appointment, typically. If they're coming back and their posterior teeth are not touching, so they've suffered some kind of a difference in because they're using a mandibular advancement device, we don't make an AM aligner at that stage because it's not a rehab device. It's an index for where they came from device. So if they have lost their AM aligner, that's where Keith's idea to have a second one at the ready would be able to give them a way to get back to where they came from.
So what I do is I actually have the patient fit the aligner themselves every time. It's much easier for them to do it. So they try it in the mouth, they feel it, they feel the anterior guide. We have them in the mirror, just like we did in the video, and align it in the midline. As you saw, heat the bite plane until it just turns clear. It shouldn't be floppy. It should, like you saw, that lady turned it over and over, and it just kind of folded a little bit, but it doesn't, is not really floppy. So that's a real key to it. And the dentist or assistant can heat it up and then hand it to the patient. But the patient should put it in their mouth. I think works a lot better.
Yeah, we use an Insta-Hot in our office. I think it's 106 degrees or something, and that works perfect by the time we get it back.
And so just that pretty simple. Just have them bite in and make sure that they feel their master muscles. And before they put it in their mouth, have them place their fingers on their master muscle, have them bite down hard and tap their teeth together, and they know what centric or maximum cuspation is. So it's an education of the patient to not only now, but also as they get up and do this every morning, they know where their occlusion should be.
Yeah, we have them lift their tongue a little bit and lay it over their lower teeth and then bite up into it. Don't try and place it over their upper teeth and then have them bite their lower teeth into it. It's really hard to keep it aligned over the occlusion that way. Much easier to put it over the lower teeth and have them bite up.
So, that's pretty straightforward. Have them bite down. Masters feel the same.
Yeah, they don't have to keep clenching together for 3 minutes. That's tiring. But once they've bit all the way through it, we say, okay, you can relax, but don't move your jaw. And what's not on the video there is, she's a model, she's doing it well, but we have our patients specifically put their lips together because that straightens the tab out.
That's a good idea because it's not down against there. So it really is that patient holding it and they're doing it. And so it becomes, they have a good feel about where that device is.
Yeah, then what we do is we have them open. We kind of tease it off the teeth a little bit. If it can be a little sticky depending on your timing here. And the video says if it's still sticky, you haven't waited long enough. Well, sometimes I guess I'm impatient and I tease it off the teeth. And I just have them bite down into it again. Tease it off, bite down in, and then it's easy to take out. And it comes out, and I drop it into a little dish of cold water right there from the tap or your refrigerator. And there we go. We've said this many times. You got to make sure you be able to see through it all. So look at this. Now, what happens if they come back and they've done something bad to it? Both these videos are like that. So let's see what Keith says, what I say.
I don't like the way that looks. So I'm going, and particularly in the front, it's not thin enough. So we'll just
Of course, if they have a big overjet, they won't be thin there necessarily. So he dunks it into hot water. What does Steve do to this patient's AM aligner? One of our patients came in today and told us that she accidentally dropped her AM aligner in a cup of hot tea. So let me show you what we can do with a new irradiated AM aligners when somebody makes a mistake like that. Doesn't mean that they can't have an AM aligner again. And all you have to do in your office is set up the environment to where if they make a mistake like that, they call you up and say, I messed up. And then you bring them in and fix it right up for them. So it's a good customer patient service thing that gets them back on track and helps meet your treatment goals as well. When an AM aligner is ruined by anything, you can put it back in boiling water. We use a little hot pot and you boil it for a little while. It doesn't take very long, but you do have to boil it. You can't just put it in warm water, but by boiling it, it returns itself to its unbid on shape. So just like you got it out of the package. Then of course you put it back in the patient's mouth, they bite on it in MIP, take it out and put it in cold water. We use some cold water from the refrigerator that sets it really nicely. And then of course we put it back in the patient's mouth. Just like that. It's good to go. That one's a little brown because what did he do? He dropped it in some tea. they tend to stay nice and clean. When we see these coming back after, now we've been using it for what, guys, about a month now, or a year now rather.
Yeah.
And they're coming back for their annuals and they're bright white. They don't stain.
I don't like the way.
There we go.
For some people who might like not having a posterior part of it, or if somebody's arch is very abnormal, you might only want to use the anterior part of it, particularly if they're missing teeth. So do you have the heavy duty scissors? So what you do, cut off the posterior part. And like this. So now you just have the anterior part of it.
You can't do that with that thermocryl with the Kevlar in it.
Okay, so now you've got this.
Yeah.
Same sound.
You're not hearing the sound of the me tapping my teeth together, but it's what I do is with it in and with it out, the sound is the same. So I know I'm back in initial maximum intercuspation.
So what questions you guys have? Let's see. So, Keith, can you see the questions here?
I cannot.
Okay. So the newer one is harder to place on the arch. If it doesn't seat properly, it's difficult to reposition. Any tips?
Just like we said, have the patient put it on their lower arch, have them bite down. If it doesn't work, heat it back up, do it again. I've done it 3 or 4 or 5 times to do it, but always put it on the lower arch. I like the patient to do it themselves. They actually move it with their tongue. They can feel it. Have the patient grab hold of it and put it in before you heat it up. So all of those, we're just not finding. We initially found, when we tried to do it, it was much more difficult, particularly putting on the upper arch. when we do it, put on the lower arch, the patient does it. So that's the way we've been successful. How about yourself, Steve?
Well, I noticed when I would put the thermocryl over the lower cuspid to cuspid and ask them to bite together, a whole lot of patients would try and bite their front teeth together. They would try to bite through it edge to edge. And I would try to convince them that, no, what you have to do is bite your back teeth together. With this device, what we're doing is telling them to bite their back teeth together, and they feel something back there to bite on. So it makes more sense. I've had 0 people posture their jaw forward and try and bite edge to edge like they used to do with the thermocryl over the lower incisors. So I find it to be a lot easier to position. We see a lot of people, and there's human variation out there. So people are going to, struggle with this. Some will struggle with it, but not most of them don't. It's much easier. So another question is, I couldn't get the patient to bite through it and make it almost clear at the cusp tips. So should I try a few more times? Well, what I would say about that one is that, first of all, you want to make sure you know that their teeth in fact touch. When I do these shim stock baseline measurements of every tooth pair around the arch, and it's surprising how many times there's a few teeth that don't touch. So it could be that you have a patient with already a posterior open bite. I'm not positive about that, but that's what I would check on. And if you're finding that patient who doesn't bite hard enough, you can just reheat it and say, look, no, you got to squeeze on it. You got to squeeze hard on it. Feel those masseters out there. I want you to feel that muscle working, kind of a thing. Just coach them. Keith?
Yeah, I don't have much to say. I just say, train the patient first, have them bite on their back teeth and feel those master muscles, and do it several times so they really understand how hard they need to put and what they do, because you can't recruit those master muscles until your back teeth are together. If you got just your front teeth together, we have proprioceptions that won't allow us to fire off those master muscles. So the real key is to make sure that the patient knows that they got to make their master muscles move out and their fingers move out. That's what I tell them.
Are there any tooth shapes, Keith, that you worried about making this, like worried about locking it in, or some kind of anomaly with your tooth that you might think it would be difficult to get it back off the teeth?
No, that's the other thing about this compared to the other one. That had more material, more thickness. It would grab a hold of teeth better. This is so much thinner that it flows better, that I've never seen anything that really locked it on the teeth.
Okay.
So I haven't had that experience.
So somebody with a big overjet, so they have, and let's picture a skeletal class 2, so their mandible's way back, because they can have a big overjet in a skeletal class 1 with a narrow arch also. But if they have a big overjet, is there any tips to position the device that way?
The main thing is, I think, is put that little notch right in front of the upper anterior teeth and let them bite on it. Because if you get enough teeth into this, all the slopes on that from anterior to posterior will help reseat the condyle in the right position. So you don't have to have all the teeth in there. You don't have to have it perfect. But it still works. It still works well.
Yeah. So in the thermocryl, we would have to stack up a big pile of thermocryl just to reach between the lower incisors and the upper incisors to get some kind of a lever action or force distally on that mandible to reseat the condyles. And if you use a anterior only thermocryl, you have a large lever action there, so it's hard to keep it stable. Whereas this one, you're using the posterior, at least that back to the bicuspid is plenty long to reach that, and you still got all those slopes to help reposition everything. Yeah. And so, when do you need to trim that aligner? You mentioned in the video. So go over that again, Keith.
If you have somebody that has no posterior teeth, just bicuspids, or just anterior teeth, you'd use that, or missing teeth, or something where, ultimately the patient, you're having difficulty getting it over the occlusion. Just cut the thing off and make it just an anterior jig like we've done before with the just over the canine to canine. However, with this one, you can go back to the first bicuspid or second bicuspid, and that's plenty good. So if you're having trouble with some patients, you can just trim it off and use it like that.
So, well, what do you do? So now we got a couple questions about, well, okay, they didn't use their AM aligner. So, okay, great. Now what are we going to do? What are you doing to rehab that that MIP if you can? What's your strategy?
First of all, when they're in the office, I have them put their fingers on their condyles and push on their mandible and push that jaw back up to the condyle to see if we can reshape that disc some and get their teeth back some like that. And we will do that and remake the AM aligner. If they lost that, then remake the AM aligner in that position and try to get them to exercise in that position, and then do that. If they're still in an appliance, it's almost impossible at that point. And my feeling is, I say, it's better to breathe than to eat. I can manage your eating, but if you're not breathing, you're in the box. So we've got to look at what the morbidity is from not breathing as compared to the morbidity of moving the teeth or having your bite off. And so it's one of those caveats that you explain to patients, but it's rarely do I have a patient complain about it, even with some of the worst bites that I've created. And as I say, I've screwed up more bites doing this than I ever helped bites when I was doing restorative dentistry. So anyway, but people are alive, so we're treating some pretty sick people.
Yeah, there's a number of ways we approach this. Somebody comes in and shows me their posterior open bite, and I ask them some questions. I say, are you having any trouble with your jaw joints? Are you having any trouble with your muscles of your chewing, or your teeth hurt anywhere? Is chewing a problem for you? And I tell you, in hundreds and hundreds of patients, the number of people who have answered yes to even one of those 4 questions is less than one hand. Some of them say, yeah, chewing's different, but they're not having painful problems with that. And then I go back to why they came to see me in the first place. Not necessarily the OSA part of it, but their problems in life, the snoring, the worry about oxygen levels to their brain, whatever it was bothering them enough to come get an appliance in the first place. And I remind them of why they wanted that. And then I also point out that, gosh, guys, in medicine, once you're diagnosed with a problem, really nothing's free after that. If you don't treat the problem, you're going to be sicker. If you do treat, and all the treatments of most everything have side effects. And so I wish there wasn't one, but this is the one that we talked about from day one. And so since you're not having a lot of troubles with this, let's talk. What else can we talk about? Let's talk about fishing or something, because it's really just as important. Now, we don't dismiss it, and we're very, very good doctors about this, and we pay attention to our patients. But I don't want you to be over worried about this. But on the other side of things, given as easy as it is for the vast majority of our patients to come in and report and show us stable occlusions over years, there's no reason not to go for that as our goal. That's what we do. Now, rehab, what we do in our office, if they come in and they show us this and they want to work on it, and we have their history. We know what their jaw joints are like. We know we're probably dealing with the changes in the retrodiscal tissues or the length of the inferior lateral pterygoid or something like that. We give them exercises. And Keith, we go back to that bite guard material that you started cutting up years ago. And we give them cut up bite guard materials, and we have them use it like a lucid jig. And so they put it between their teeth and they rock their lower jaw back and they squeeze or they push with their hand or something to put directive forces on the parts around the condyle to try and rehabilitate those issues. We don't go to MRIs. We don't do a fancy diagnosis here. We just do physical therapy, range of motion things to try and get their jaws back. And we've had a number of patients that do that a little bit, and then they come back in and we check the shim stuck, and whoa, look at that, it's back again. And so then we make a new AM aligner. By the way, we're converting all of our old AM aligners to the new ones every chance we get because they work so much better. But that's what we do. We do exercises. We do the tab therapy, we call it, which is a Lucia jig therapy, and we help patients see that if they do these exercises, maybe they get some pluses to it, but we do turn them out less worried than they come in with almost all the time. What else? Does a patient's upper incisor should touch that tab? Yeah, you just put that little block on the front of the front teeth because that gives them a place to posture it when they put in. They feel that touch the front of those upper incisors, and that's a really good thing. Keith, we're running out of questions here. Anybody else have a question for us? Not that. I'll stop my screen share. Oh, I actually got one more slide, don't I? No, hang on. I got to stop this. Here we go. Don't forget about your free mug. Put your address there. We'll send you a mug. Excellent. And then here's our contact information. And Keith and I, we both love to get questions. So if you have a question out there that you forgot to ask or something comes up in clinic, please reach out to either one of us at these email addresses, and we'll do what we can to help you out. We both have long history of that. Whenever anybody came to the Pankey Institute, that's just part of the deal, is that you join the family and you have the right to ask a question anytime you need to, and we'll do our very best to help you with that. So never hesitate to reach out to either one of us there. And Kelly can answer all things airway technology. How do I buy these things? What's involved? Remember, this is independent. You don't have to use TAP appliances to use AM aligners. We think TAP appliances are great, but other appliances are useful all over the place too. And you may choose those for an individual patient. But you can buy the AM aligners separately and have them to be your standard for helping your patients of any mandibular advancement device get back into their normal occlusion in the morning. I will stop my screen share.
Somebody said, what should I do with my old bunch of thermocryl beads?
Oh, yeah.
Oh, I use them fixing shoes, putting bumpers on cars with. Man, you can use it for anything. It's the damnedest material I've ever seen, you know.
And I want you to clear up something. This isn't plastic, is it, Keith?
It's not. It's a long chain polymer made that is organic, made from corn, called polycaprolactone. It's a lactone. And it's used in, when I first bought it, I called the guy up at Union Carbide and I said, well, can I buy 5 pounds? And he started laughing. He said, that's our size that we give for just a trial thing. He said, you can buy in either 55-gallon drums or train car loads. And they use it in all kinds of plastic garbage bags because it will deteriorate in a landfill. So that's the story of thermocryl.
So it deteriorates in a landfill.
It will deteriorate. They combine it with other plastics, and because it is a corn-based polymer, that it will it's organic and it will deteriorate in landfill. So they use it a lot. So anyway, kind of neat.
Yeah, it is. I didn't know it was corn-based. I knew it was plant-based. I didn't know it was corn-based.
Yeah.
Well, I think that's all we got for you guys. Thank you for being here with us. Thank you for your interest and good questions. I like that. I think we got, what should we do with it? There we go. Yeah. People are going to get their mugs, Kelly. So you got some shipping to do ahead of you there. Excellent.
All right. Thank you all.
Thank you.
Enjoyed it.
Good night.
Thank you, Steve. See you.
See ya.